Probably, maybe. So what I would love for us all to do, or at least we can all share our experiences. I do best when I'm talking and it's interactive. Okay, so any students who have had me in the past know that if you don't talk to me, I get kind of antsy a little bit. So I hope that this is going to be an interactive session and that you'll share your own experiences. There are some points at which there's required interaction. Okay, there'll be a question on the screen that you'll think about, and so hopefully that can spark some conversation. I don't claim to be an expert in pain neuroscience education. I am extraordinarily interested in this topic because I am very, very interested in pain, and particularly pain in older adults, because I've seen, and many of you have also seen, the very bad effects of having a chronic pain condition in particular can have on individuals. Some individuals it has a huge negative impact, and some people it just doesn't seem to bother all that much. They may have the same radiographic evidence of pathology, but some people do well, some people don't do well. I find it fascinating. So much of my work so far, research-wise, has been in working on pain self-management, and I've come to understand that while in all of my pain self-management programs that we have implemented in senior centers and in home care and skilled nursing, not skilled nursing, but in assisted living facilities, they all have something called pain theory. And all of the therapists that I've trained in these different programs, they feel extremely comfortable teaching pain theory. But what one person thinks of as pain theory and another person thinks are two completely different things. And I've come to believe, I don't have sharp and really strong evidence on this, but I've come to believe that really that's probably the most powerful component of any pain self-management program that I've been associated with, because the way we think really affects the way that we feel and the way that we act. And so that's what we're going to focus on tonight. So I have objectives, of course, and some of this is going to be more about pain neuroscience, but some of that, I do hope you're going to come away with some real skills. You'll be able to explain and identify topics and discuss relationships about patient expectations, which I believe is absolutely fundamental to most of what we do as physical therapists. But here's the thing. I want you to be able to integrate basic pain neuroscience education principles into practice. Basic level at this point. You won't be a master after this session, but you should come away with something there. And most importantly, that you'll start to recognize, pay attention to the words that you hear yourself speaking and you're hearing other people around you saying that might influence the way a patient perceives their own condition that may not be necessarily beneficial. Okay? So the language that we use can be really powerful in setting expectations for your patients and in achieving outcomes. So I have no disclosures personally with this topic. However, I am going to be making a plug for a real neuroscience education course that's going to be offered at Upstate in November. So more on that later. Okay? So is there a pain epidemic going on, do you think? So look at the literature. There certainly is a good evidence that there are a lot of people in the United States in a lot of pain. So using the Medical Expenditure Panel survey, over 100 million people in the United States have chronic pain. I'm going to emphasize mostly chronic pain because that's where most of this stuff really steps in. We'll talk acute chronic in just a bit. So a huge amount of money is being spent on the health care, medical care for people with chronic pain, over $560 billion a year, and this was in 2010 dollars. And lost productivity is another huge amount of money, between $261 billion to $300 billion in lost productivity. And so it's really interesting to me that there is so much research and so much talk about heart disease, cancer, and diabetes, and those are certainly very important medical problems. But pain is one of those really, really huge medical problems that's much more pervasive and more expensive. So that's why we're talking about it today. So I just wanted to introduce this concept to you. Have you heard of the Washington Group pain categories? I think this is pretty cool. What they did, there's this group of people who look at the frequency of pain that people experience, adults experience, and the bothersomeness of the pain and categorize that according to whether it's not very intense. They take that as sort of a gross measure of intensity. And they found that 14.4 million adults have the highest pain frequency and bothersomeness in the United States. So that's people really having a lot of impairment due to pain. So, of course, we can expect that with that level of pain, you're going to have higher health care expenditures, higher utilization, greater disability, worse health status, worse quality of life, for sure. And I always like to point out that this is not a fair game. All right? Slide shows young people in the purple, middle-aged people in the light purple, and then older adults in the green. So as we might expect, younger adults are experiencing the most severe category of pain less than the others. It may be surprising to some of you that in some race and ethnicity groups that older adults are less disabled, and that's kind of one of those controversies. Are we less disabled as we get older, or less suffering associated with it? But there really is a difference between Hispanics and non-Hispanics. Non-English speaking Hispanics are probably less well off, but really the non-Hispanic blacks are suffering or have a greater intensity. Non-Hispanic Asians are with the lowest level of pain. I'd just like to say something about race and ethnicity because especially in the Syracuse community we do have a great diversity, and I think it's extraordinarily important that we pay attention to our patients' racial ethnic background. Enough said. All right, pain is a vital sign. How many of you use it that way? How many of you assess pain on every single patient visit? It's required in many settings, right? My daughter was in the hospital this summer, and she didn't have a pain condition going on, but everybody who walked in the room, do you have any pain? Do you have any pain? It's like, how many times in one day could a 17-year-old girl be asked about pain? It's like, I'm starting to think maybe I should hurt. I don't know, the IV site, something like that. But it's amazing how many people really ask. And that's important. But is it really doing our patients any good? Is perhaps the emphasis on pain evaluation at every visit making our patients pay more and more attention to their pain? So I think there's a balance there. And there's some interesting emerging research that shows that really our routine monitoring of pain intensity doesn't necessarily result in improved patient care. So it's one thing to ask about pain intensity, but then you need to act on it. And the questions that these authors, those two studies here raise is whether or not is it pain intensity that's the most important thing, or maybe we need to be paying attention to other aspects of the pain experience and not just the intensity. All right. So, of course, I'm just going to have to go here, right? We all know that there's an opioid epidemic right now, or they call it an epidemic. There's a lot of misuse of opioids. The prescription rate for opioids has just really escalated ever since we had this war on pain that began back in the 1990s. And we're starting to finally see some tapering off. These are the number of prescriptions at U.S. retail pharmacies in the United States in the millions of prescriptions filled annually, 216 million. A lot of drugs going out there, a lot of opiate drugs. And I'm not putting up there the parallel in heroin epidemic because we know that once you're addicted to prescribed medication, if you no longer prescribe that, you will go elsewhere to get it. And we see that all the time, right? So this calls for non-drug management. I have a couple of articles for adults, but really there's a big, huge call for non-pharmacological pain management across the board. And so our professional association is really resistant. And how many of you are hashtag CHOOSEPT, that we are the alternate, one of the prime alternatives to medication management of pain. How do you feel about that? All right, so we're going to be having, if this publicity, what do you call that, this public awareness campaign is really effective, we're going to have a whole lot more patients, possibly in our clinics, that are looking to us to be the people who help them manage their pain or relieve their pain. And many times, because we all know that drugs supposedly relieve pain, so we're going to be looking for that. So what are the PT tools for pain? I didn't put a question mark after this, but this is one of the participation moments for you. What tools do we have in our toolbox? Pain or to treat pain. Yes. Generalized movement. Mm-hmm. Modalities like? Electrotherapeutic modalities. Education. Ding, 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 because, of course, that's in the title of this. All right, so we pretty much hit the ones that I have on the next slide. But instead of just generalized movement, I really think about exercise and therapeutic exercise in particular to address specific needs of the patient. And that's what we're going to be doing, very specific to what that individual needs, according to your careful examination. Manual therapy techniques are increasingly recognized and increasingly important in our physical therapy treatments of many patients with pain. So that's something that we're seeing a lot of literature on. So pay attention to your hands, to your manual therapy techniques. Physical agents and modalities. I don't know. Sometimes people call modalities everything, and sometimes they just call them the heat. That's why I asked you which ones. I call everything physical aid. But education, obviously, is the thing that I'm here to talk to you about because we have a lot that we can do to affect patients' beliefs about their pain just simply by what we say to them and how we educate them. So, education. Let's take a little look here at this particular patient. We have a 36-year-old man with acute back pain who started the onset with lifting his 3-year-old son. There are 2 other kids at home, 1 is 6 years old. The physician diagnosis is a slipped disc, no more information than that. Not taking anything other than Tylenol, works in HR, currently leave, and eager to return to work for financial and social reasons. That's a real general description of a patient.
Wally, get off the door.
I can teach this patient. Okay, ergonomics, sure. Okay, good. What else? Body mechanics, right. Along those ways, not how you're moving, but then also at work and also exercise. Good.
I'm going to dissuade them with the notion of that.
You're going to dissuade them with the notion of that. Okay, we'll come to that again. Anything else?
That was what it's like. You educate them on how you're going to help them out.
Okay, so you're going to start with the diagnosis and educate about the nature of that diagnosis, but then move on to self-management, what they can do to help themselves. Am I saying that correctly? How we can help them and how they can help themselves. Good. Anything else that you can think of? Okay, so here's what I thought y'all might say. Looking at the anatomy of the injury, perhaps. Okay, so talking about what a slip disc is, whether or not it's a valid diagnosis or not a valid diagnosis, we might want to indicate to the patient what that means. So, movements that cause injuries, so the biomechanics, the ergonomics, and the biomechanics of the injury, perhaps. Have any of you ever used the jelly donut analogy for a slip disc? Okay. So have any of you ever wondered why you did that? Whether or not has it been an effective way of teaching patients? Keep that in. All right. So you can talk with patients at the level that they're able to understand. But there is some literature, as you know, that are starting to question whether or not when you push on the back of this donut here, the disc would really protrude more. So the actual mechanics of the disc and the protrusion may not be quite as simple as the jelly donut implies, although it would be really wonderful because it is quite a dramatic way of describing things. It may not, likely not as accurate as you would like it to be. Okay. Have you ever used pictures like this to describe, to show the patients how you want to avoid this bending forward and then moving, so forth, and indicating that you're going to be teaching the body and appropriate ways of moving. Those are things that you use, right? Okay. All right, so let's say we teach our patients these things. We do an excellent job of teaching these things, and we combine this with excellent therapeutic exercise and manual therapy. What do you think this patient's outcomes might be? 36 years old, 3 days post-injury, acute back pain. What's the expected outcome? Yeah, they're going to get better, right? Because most of the people who have acute back pain resolve within 2 weeks. I think some of that are 50% of people resolve on their own without us within 2 weeks, honestly, and 80% are resolved completely by 6 weeks. So that's a really great outcome. By coming to visit us, you can help that process along. We can possibly prevent additional injuries, increase knowledge, movement, ways of moving and strengthening, and so forth, can probably help in addition to just that natural history of low back pain. But as you know, sometimes it is not so simple. Sometimes patients don't come to you like this. And so here we go. I'm going to read this one. It was too much to put on the slide. A 36-year-old man with low back pain present on most days for 6 months. The reported mechanism of injury was lifting a 3-year-old screaming child. He has 3 children, 1.5, 4, and 6.5. Originally diagnosed with a slipped disc, MRI shows disc herniation at L4 or 5. Pain in his back is constant aching, rated a 6 out of 10 with lifting and rotation. His daily activities are watching television, tries to help around the house, no regular exercise, it just hurts too much. He's on short-term disability but is not sure he can return to his job. He tried PT and he really loved the ultrasound and massage. He did the exercises for a while but then stopped. He's had several injections. He doesn't really know what those were for, but the doctor recommended them. They worked for him. Maybe he got a little immediately.
I'm going to be done like
no long-term effects. Wife is working over 40 hours a week. Mother-in-law is helping with the kids. All right, not quite so simple, right?
Possibly.
So let's say our patient also has a brother who had back injury and is now on permanent disability. PT was no help at all to his brother. This patient, our patient, not the brother's main source of companionship came from his work buddy. With him he could commiserate about the stresses of child rearing, and he doesn't have that anymore.
Yep.
All right. How common does that sound to you? Does that sound more like a real patient? Or somebody, you've seen some people who look like this, right? Some patients who are presenting in a much more complicated manner than those with an acute injury. Or certainly somebody who has a knee, ligamentous injury. Not so simple. And so this is a nice picture that comes from Psychologically Informed Interventions for Low Back Pain. There's a wonderful journal of physical therapy back in 2011. A good portion of it was really all about this sort of thing. So this diagram, I'm sure you can't read it completely, just points out that there are nociceptive and neuropathic mechanisms that kind of feed into the pain. But then there's all of the information that you're getting from families, employers, friends, coworkers, other healthcare providers, because we don't work in isolation. So the pain is associated with reduced activity, beliefs and thoughts about prior treatments and how his brother never got any better. That's going to impact his pain. Repeated treatment failures, long-term use of analgesic drugs. Fortunately, this guy never developed that problem. But he has loss of job temporarily, not really doing all that much work. And so you're getting the physical deterioration, depression, anxiety, just despair. And along with that, oftentimes there's a decrease in sleep, changes in appetite, just really excessive suffering and disability. Okay? It's a pretty sad state of affairs, but it's not an uncommon state of affairs. This is why many people use drugs to try to relieve this. So just want to just kind of to reiterate, the psychosocial influences on suffering and disability are just tremendous. So on the negative side, things that facilitate pain, that make the pain worse, are things like fear, the fear of the unknown, the fear of pain. Catastrophizing, everybody knows that word, so everything is just terrible. But it's never going to get better. It's always going to be like this, and it's just interpreted in a very negative way. Depression, we know, is associated with hormonal changes that can be really devastating in terms of getting a depression. Low expectations, social isolation, all these things are really facilitating terrible pain experience.
Somewhere.
Many of our patients have.
We're basically ignoring them. They're doing their own thing.
Some of these
like one of them is hanging from the balcony, on the roof. That
resilience, just that ability to spring back.
Oh, your mother is
from things. So people who just have a general positive affect, those are patients you love to see, like we can do anything. And those who have strong family and friend support tend to do much better than those who don't. So to not pay attention to these psychosocial influences for a patient who has a chronic pain condition is to only look at the teeniest, tiniest part of that pain picture. If we're only looking at the biological or the physical aspect of the pain condition, we're going to be missing a whole lot that could potentially influence the frequency. Transitioning to this, I didn't know quite how to do it, so I just put the slide on there. How many of you are familiar with the term central sensitization? There's some excellent information out there. This is basically just the nervous system gets,
what is it?
Hyperactive, hypersensitive. So, I mean, I think about it as the fire alarm that I had in my first apartment, first moved up here from Dallas. And anytime I would turn on my stove, the fire alarm would go off. I mean, has any of you had that kind of experience? Okay, so my fire alarm, my smoke detector, I guess that's what it's called, it just was really hypersensitive. It was absolutely no good to me at all because it's so high to go off at any old time.
I'm doing work, baby.
Think about this. Your nervous system is hyperreactive. Sometimes, not all is associated with chronic pain. We all know patients don't really catastrophize or have a hypersensitive system, or not excessively, but some patients do. So do you know the term allodynia? This is where you would feel pain with things that are not normally painful. Some of you who are more seasoned like me might have learned the Waddle signs, where you would be trying to test for organic signs of pain, and so you would do some brief axial loading, just putting some pressure through the head and seeing whether or not how the patient responds to that. And if the response is, that's hurting me, according to Waddle or Waddell, I don't care how you say his name, that would be a sign of non-organic pain. In other words, that there's something in addition to whatever is physical going on there, there's something else in there. And there are a number of other Waddle signs, but that's the one that's the easiest to demonstrate here.
Could you say something else for the webcast viewers? I guess someone is muted their phone or their computer, and it's distracting to the other viewers.
Did you hear that? Someone has not muted their phone or however you're watching, and so if everybody who's watching from a distance, just make sure you're on mute.
Thank you.
Thanks very much. Okay. So you're doing something, a movement that would be expected to cause pain, but the pain response is out of proportion with the actual insult. Okay, so central sensitization, you often have those kinds of responses, and there's certainly an increased emotional distress associated with the pain disorder. Okay, doing well. Nobody's talking to me too much or challenging me just yet. In this kind of a situation, these images be helpful. So they're just putting the regular jelly donut in here. I thought I'd put one from the web. Just really much more dramatic. Would this be helpful to a patient who is in a state of heightened anxiety regarding their condition? I'm seeing some shaking of head. No. Because what does this do? Especially because it's red. If it was purple, it may not be so well. If it was yellow, maybe not so bad. Oh, no, that's pus. I guess any old way, it's going to be pretty bad. But in general, the red here, the red over here, red is that alarm color. You're having these things, and the patient is looking at these things and thinking, oh, it's horrible. Look at that. If I bend forward, I'm going to have this terrible pain, and it's going to squish my donut out the back of my back. And then what will I do? It's these things, they're very innocent images and analogies, seemingly, but maybe misinterpreted by an individual who's really suffering and not interpreting things in the kind of rational, non-pain manner that we all would deliver it. Winky. Okay.
So we're going to find that those are legitimate metaphors to use?
No, I'm not going to be working under that. I was going to try to ignore that. I was trying to skirt around that question completely because that is another whole discussion. But there is, I mean, let me go ahead and acknowledge this. Exactly right. Is that these images, we're increasingly understanding that this whole idea of the disc protruding out the back when you bend forward is just not a legitimate thing. You know, I kind of indicated it a little bit earlier. The research is showing really the case so much. Did you want to expand any further on that?
I'm not concerned so much about the mechanics of it, so much as that we don't know which patients are going to move from that acute to that chronic state.
Yeah.
And so if we start out with this, and we have that patient transition set 1 out of 10 for 1 out of 20, then make this way in transition to chronic pain, they're now working with a metaphor that can be received as
Hope you did. That's true. So if we start off this way, we're educating people in this manner, and those who don't get better, that 20% who don't resolve, using back pain just as the example because it's easy. The 20% who don't get better and do progress to a chronic condition, their reputable provider, have given them this image about what's going on in their back that may not be valid at all, likely is not valid at all, and may be contributing to that whole experience. Thank you. All right, here's some more interaction. So you're going to think for a minute about descriptions that you have heard other people use, because you wouldn't do it yourself, right? Descriptions that you may have heard people use to describe injuries that may not be so helpful. Okay, so those of you listening from home or elsewhere, think about that. What kinds of things have you heard people say that haven't been so helpful? And chat among yourselves for a minute. This is where I drink water, and you chat.
even the degree is great. You don't have time.
One that I hear, I understand that.
We can just generalize that people who
Okay, do we have some good examples? I've got some great stories. I want to hear yours.
Because you can't, in many insurances, you can't get an MRI until you try PT. So tell them, just go to that PT first, and when that fails, you can come back and get your MRI.
Oh, the doctor's saying that you're going to fail, PT's going to fail, and then you get your MRI. Bone on bone. My sister has bone on bone arthritis. My stars. Yeah. Degenerated tendon. Degenerated anything, right? Degenerated anything. Other good things? Yes. Chronic. Yeah. So increasingly, people are trying to say persistent pain. That's one thing. So one of my favorite former friends, this is why she's not my friend anymore. I moved away, and she stayed in Texas. One time, we were watching her treating a patient who had neck pain, and she took one of the full-scale models here, and I only have one of these, and this sits. And we saw, and Kathy, what are you doing? She said, well, I wanted to show him, he has whiplash. I wanted to show him why he hurts. And so he bangs the head around like this. Oh, my stars. Yeah, I would hurt too. Oh, my goodness. And then I'm going to just say one more because it's just too priceless. I heard it relatively recently, a woman who was coming to us for actually participation in the study that we're doing, whose physician had told her, okay, she has lumbar stenosis, and that if she ever falls, she's going to be paralyzed forever. Man, would you want to move?
Education who had his MRI results rushes in that his spine was narrowing.
You could if you wanted to leave Saturday and go Sunday.
But what he heard was his spine was narrowing, and in the one day, it came out in conversation. He's like, well, one day it's just gonna.
Yeah.
What? And he's like, well, that's what they said. My spine's narrowing. One day I'm just gonna wake up narrow.
Yeah.
I'm like, oh my God.
Yeah. So the fear of paralysis. Why would we ever say things to people? What world? Yeah. Oh, yeah. Okay. Ulterior motives. Oh, geez, I'm so innocent. Yeah. So I guess maybe that's one of those things to kind of encourage a non-conservative approach. But it's not helpful to those patients. Even after surgery, they're not going to be so well off, honestly. That surgery is never going to be the answer to everything. And so they're going to have those images forever in their mind. And then that really creates a huge barrier to rational approaches to treatment. All right. So pain neuroscience education is different from traditional education that we might have done back when I was going to school originally. This was really about the injury anatomy, the biomechanics, the reducing stresses on the joints, and so forth. And so that more biomechanical model, biomechanical approach to care, which works sometimes, it doesn't work all the time. The pain neuroscience education is really taking a different approach and really teaching the patients about pain. So what is pain anyway? So why do we have pain? Why do you have pain? And why is pain ruling your life instead of you ruling pain, right? So that's basically the approach that you're going to be taking with pain neuroscience education. Don't avoid it. A lot of times I think physical therapists don't want to talk about pain. We want to treat function, right? But for patients who are suffering and have been suffering for a long time, ignoring pain and suffering isn't going to be really earning you any brownie points with that patient. It's probably, and it's going to be ignoring all those psychosocial factors. So it's not going to really help. It's not going to be that complete picture that you may think you're delivering to the patient. So just go ahead and, bite the bullet. Go ahead and let's talk about pain. That's the approach now. So the kinds of topics that you do, what you want to do with the approach is really acknowledge that the patient's pain is real, because so many times they have heard that their pain is in their head. It's because they're that hypersensitivity and little movements hurt, and they haven't been back to work for so long. They aren't doing anything. People are thinking that they're working the system, right? The people are out on disability. Oh, they're at home, just soaking up the dough while they sit there and watch The Price is Right. But the patient's experience, got to come in with the realization or the recognition, or helping them understand that that their pain is real. They have pain. I hear that you have pain, and let's go ahead and talk about what pain is about. So pain has a purpose. The original injury that you had, there was a reason that you had the pain, and that's because pain is an alarm system. It tells your body. It's your body's way of telling you that you better watch out. Something bad's happening here, okay? So it's like that finger in the fire, stepping on a nail, any of those painful conditions. If we didn't have the pain response system, we'd be, walking around with nails in our feet, and that's no good. So pain has a purpose. But sometimes that system goes awry. It gets uncalibrated, and we need to recalibrate it. It's gotten too sensitive. You're feeling pain where there is no real insult to you, so we need to kind of retune the brain, retune the pain, and get you going again, okay, so that the pain is not ruling you anymore. So the topics. The topics are that whole purpose of acute pain and the pain pathways. Some people describe the pain pathways, some of the people who write about this, in relatively great detail. Some just the regular pathways that you have an injury and it goes up to the brain where it's perceived as pain. Some go through the point of that, but also descending inhibition, and looking at the other effects in the brain. It's going to depend upon your patient, how interested they are, what level of pain physiology, pain pathways they really need to know. But they need to know that pain is perceived in the brain. That's the most important thing. So one of the things is with one approach is that, your pain is all in your head. It's in your brain, because without your brain, you wouldn't have pain. Okay? So that's where it's all interpreted. It's important that patients know that even though their pain has been around for 6 months, 6 years, 36 years, that the healing process is come and gone. That whole process of healing after that initial injury, that's done. That's gone. That's not what's going on anymore. You're not feeling tissue damage anymore. That's not there. That's what you're going to heal as much as you're going to heal at that point. So teaching them about that healing timeline, that typically in injuries, the healing is completed within 3 to 6 months. And then thereafter, there may be some residual tightnesses or things like that, but really the injury is no longer the problem. It's not a tissue problem anymore. It's more of a pain problem. Does that make sense to everybody? Okay. So other things that we can put on this one. Here, I did. So then people who have had pain for an extended period of time need to start to understand that how things progress to being chronic. And this, again, doesn't have to be in great detail. It depends upon your patient. And I'm not going to go into great detail here because there's this excellent course coming up in November that can go into great detail, and you'll be able to take it home with you and use it continually after that level of detail. But talking a little bit about plasticity, about how things mold. We used to think that the nervous system was the nervous system and it just didn't change. And if anything happens inside your brain, that damage is there forever, and now we know that different parts of the brain can take over. Talking about plasticity. Plasticity has a whole lot to do with that central sensitization. Most of your patients aren't going to need the details about how those two are interrelated, but understanding that your nervous system is just reacting to things that just really aren't helpful anymore. Is that really that alarming that when I pat the top of your head, is that an alarm? That pain you're feeling, it's not a legitimately injurious action there that you haven't had an injury there. So your alarm system isn't working the way it should be. This one, the impact of chronic pain on thinking. All right, so think about your patients who have had chronic or persistent pain for a very long time. So are they getting as much done as they used to get done? Okay. So I don't love the term. It really is the right word. If you are suffering, are you thinking clearly? No, you aren't. You're suffering. And there's a whole lot of your emotion, a whole lot of your body, a whole lot of your time taken up with that suffering. And so that part of your brain, that much of your brain that is suffering, is not doing all those other great things that you used to do before you had this injury or this condition. Okay? All that, you know how you used to go fishing? Nope, now you're suffering. How you used to be able to do higher order math? No, you can't anymore because you're too tied up in the pain experience. And so it influences all aspects of patients' lives. And they need to understand that. It's not that they're stupid. It's that their brain is doing something else. It's not paying attention. It's so tied up with doing other things. You're not being able to focus on the things you'd like to focus on. So that's that whole pain predominance. The pain is basically, through this whole process, this long process of suffering, of pain, it's basically taken over your life. It's robbed you of your life, okay? So we got to do something about that. And the thing that we want to do with neuroscience education is get the patient to start thinking about what we need to do is retrain the brain. The brain starts to perceive pain in a different way. Okay? We can't go in there and change the circuitry directly. We can change the circuitry by the way that we move our bodies and by the way we think. Because of this plastic, it can go both directions. But it's going to take some work. It's a process. And it starts off by really understanding pain. It's like know thy enemy, right? Okay, so if you understand pain, that neurophysiology stuff, then that's the first step in the right direction. When you get it, then you can start to conquer it. And then it's a matter of helping them shift their thoughts and their actions away from the pain, stopping those pain behaviors. I kind of hate that, but I'm using it anyway. Pain behaviors are things that you do that reinforce thoughts, that sense that you are suffering, disabled, and so forth. So consciously working on shifting your brain away from those pain, not away from pain. Reducing stress through physical exercise and meditation, relaxation, all of those sorts of things. Okay? So that's sort of really in a nutshell. That's the package of it all. All right? That you want to understand the pain so you can conquer it. And then there's a real approach. You need to really consciously work at it because it didn't just happen overnight that you had a hyperactive, hypersensitive nervous system. It's going to take a while to go back. Let's talk about that now. What comments do you want to share? Anything? Yes.
I don't know if this works. But I hear a lot that, I have a high tolerance for pain. Mm-hmm. And because you say, okay, don't do this exercise if it causes pain. So I don't know how to take that because you're like, okay, my pain's a 5, but he's saying it's an 8. Where do you
being a therapist and he's the patient? I'm not understanding.
I'm just saying that my sense of pain may be different than your sense of pain.
Okay, and of course they are. Yes, and so that is an consideration, right? That what I think is an 8 maybe a 2 to you, because I'm a wimp. So that there's that judgment piece too. And the patients that I've seen in home care that my pain's an 8. It's always been an 8. It's always going to be an 8. So using the numerical pain rating scale is a completely invalid thing. So I would say not emphasizing so much what is the number, but what is the impact on their function. Okay, because you can have some people whose pain is an 8 and they walk up to the door in a little jaunty way, my pain's an 8, yeah, and others who are, my pain's a 2 and they're creeping along. Okay, so it's really more about the pain behavior, I would say, than really the intensity. Other thoughts on this? Yes.
Just to go back to what you said about at a certain point that the healing is going to take place of the pain is a physical signal. Is there not any example where that might not be the case, where you could have a persistent mechanical sort of pain, like a distance runner who's got chronic hamstring pain, and so they're better at rest, better at not stress, and every time they stress that issue,
sure,
that they have that pain, right? And I don't know that I could say to them, your hamstring is not really the problem, it's you, because I don't know that it has. I think that there's continuing stress tissue that is bigger than pain.
That's an excellent point, and that's why they're so lucky to be having physical therapy that can help them with that, with addressing the physical issues. So I said my sister has bone on bone arthritis, whatever that is, and And so what can we do for her? Thank goodness she's going to see a physical therapist. And so, of course, you can stretch those tissues around to relieve some of the pain because, she had a look at her. You could tell she's hurting when she's moving around. But we can help address some of those things. But I think the point is that the pain doesn't need to be the alarm anymore. The alarm isn't being beneficial to the patient. The discomfort is going to still be there. But is it alarming? Is it alarm and, does it warrant hypervigilance? Does it warrant catastrophizing? So that's the thing, is you got to be able to really interpret the pain differently. So, I'm with you. There are some things that you may be having re-injuries. I get that. But the idea is a patient who is so fixed on the pain, and maybe the long-distance runner isn't a person who's so fixed on the pain. Maybe they don't have central sensitization. They're just runners, runners. And that may be a different kettle of fish than what I'm talking about here. So here it's more about the person who has pain that is really suffering and limiting their activity. Yeah, does that make sense? Is that enough of a gray area? Yeah.
What's the next step for people that don't respond to scanning? Because I've had non-responders.
Oh, I know. Non-responders are there. And so one of the things that's really difficult with pain neuroscience education is that it's all reliant on getting inside the patient's head, and some of them have so many barriers there that you can't get in. So it's that therapeutic alliance that that you have to develop a really strong therapeutic alliance so that they can believe you, that and can really trust you to do that. If you can't get in, well, let's throw it open to the crowd of experts. What do you do when they can't buy into it? When I know I can't fall because if I fall, I know I can't move too much because if I fall, I'll be paralyzed. What do you do?
Yeah, I just have a thought that I think about related exposure to exercise and how I think the learner have to deliver just enough to improve that standard. And I find that exposure to cognitive change or shift from things. And yet I would say, like our friend here, sometimes you're still not successful, even though I back off on the information and I wait because you find it. You have to think that the patient being bombarded with all kinds of forces that you have no control over. So some notice everybody, but I bet our patients can think about the rate of exposure to movement exercise.
Yeah, I love that. Graded exposure to exercise, we've all kind of got a handle on that, right? You don't just go out and run the marathon, or you don't go and address those challenging, those feared movements all at once. But the graded exposure to education, you hear it again. You hear it in a different way. You think about it in a different way in this different context. Yes, Kevin?
Maybe something along the lines of a motivational interviewing-based approach to really get at or help the patient see why they're making the choices that they're making and try and help them or change their course.
That's a great idea. Motivational interviewing is one of those tools that I think all teachers should have, but yet are so difficult, very difficult to do. But motivational interviewing, having the patient kind of evaluate their own actions and why they're behaving in this way, and they come to the conclusion that this is the new way that they should be acting. This is a new way of behaving.
From all the other providers that when they get to us, they're so frustrated because that anatomical explanation isn't describing how they feel. They don't necessarily trust us because we're not using that biomechanical explanation. So I find that to be a little bit of a hurdle, especially with patients.
Yeah.
Hear that line and get their buy-in.
All right. Right, because that's one of those things that's really difficult. So you have other healthcare providers giving this explanation that's very cut and dried. It's not really fitting in sync with my own personal experience as a patient, but then somebody else is coming along telling me something different. Is this person over here telling me that these people over there don't know what they're talking about? And so there's that whole negotiation of that understanding, trying to be respectful of other professions' interpretations of things while still helping the patient move forward.
one thing I try to be pretty careful of is I'm not physically in that space when that patient interacted with the other healthcare professional. So, I mean, I'm pretty quick to say, okay, but let's you and I talk, because I don't want to say that that person's wrong. How many times have we heard, the doctor told me blah, blah, blah? Well, I think about the third time I heard the same physician said that, you start to believe it, but it's that person's perception. So I think then, shifting it, not necessarily even saying, well, that's wrong, but let's talk about what is right, but we'll let you and I go this route.
Okay, I like that. That is, we can't really know, because everything is being filtered through our own prior experiences, our own prior knowledge, and so, we don't really know. So let's just move forward in our own relationships. Good.
To her question about what do you do after the P&E doesn't work, I think that, and you might not have intended this way, but I think it's important to realize too that to see medical panacea, let alone pain neuroscience education, the fact of the matter is a small aspect of what you're going to do to establish that therapeutic alliance. You're going to do it in a graded manner so that when that patient does have, they've seen the PA, they've seen the physician, they've read their radiological reports, you're going to have to expose them very slowly to these ideas. And even then, they're chronic pain patients. The fact of the matter is you're going to have a positive impact on less than half of them. And you might not even have only moderate effects with those that you do help. And but you keep trying, you keep tweaking, and you keep coming back tomorrow, and you keep trying to do it again. But we're going to fail more than we're going to succeed with most of these patients. Just the fact of the matter. Someone mentioned the variables are too great. You're going to see them for, if you're in an outpatient clinic, 20 minutes to half an hour with two other people in adjacent rooms. You're not going to have the opportunity to make the impact that will offset that 23 and a half hours that they spend outside of your clinic the other 5 days of the week.
One more comment, and we'll go on. Thank you.
Further to when patients come in and they say, oh, the doctor said this. Something I do is after PNE, I try to, in a respectful manner, not try to patronize the patient, but say, I want you to try and explain to me what I just explained to you, because a lot of the times that helps me tweak my delivery, and especially in regard to that graded education, you kind of hear, what they got out of it, and if you did deliver too much, and kind of tweak that message so when they go home for the next week or 5 days or whatever before you see them next, then you can grade your next thing. But I think revisiting what they heard before they leave is
I think that's a great idea. Teach back is always a really good thing. We think about having the patient teach back the exercises or demonstrate the exercise, but then having that cognitive teaching back is a really great idea. Let's see what we're going to do next. We know this, right? You're going to teach them pain biology, what the purpose of pain is, psychosocial matters. So I kind of like this, just to reinforce again, that the patients oftentimes are coming to you for physical therapy. So why are you talking to me about anything else? I mean, this is outside your realm here, right? And so there's a nice analogy that Adrienne Lowe has, is that you have the patients who have persistent pain and have a lot of emotional burden. It's like they're walking around with a lion roaring at them constantly, that they are being bombarded by all this negative stuff. They're hurting, and they're worried that they're never going to get better, and they are so down, they are just really clinically depressed, and they can't sleep at night, and their spouse is about ready to, they've had it up to here because they're having to do all the work, and there's no money coming in. Man, that's a really bad situation. So that taming the lion is a really big chore.
Water.
That, I think it's really important for us when we're having our own stresses, but with our patients, help them understand that this is a tough situation they're in. This isn't just, I have, I sprained my ankle, and, that's bad too, but there's a lot going on with this. And so helping your patient, you yourself understanding that it's more than that and that you're getting it, that the patient, that'll go a long way towards developing that therapeutic alliance. But still, they've got to tame that lion. Okay. There are confounding matters here, and some of them we've already talked about, so I don't need to really beat this into the ground maybe. But the expectations, patient expectations, can really interfere or facilitate their response to your approach in anything that you do. So the prior information and the misinformation, and we've already heard plenty of examples of that you are hearing somebody taking radiographic reports as being the absolute cause of the patient's problems, and we know that that's just not a valid thing, that those need to be interpreted with care. Okay, so I think we've done that. And so what they think is going to work in physical therapy is just really pretty cool. So I threw 3 studies up there, and let's see, which one do I want to talk about? I really love this work by Mark Bishop. So this is, and colleagues here, I guess I should say it's Josh Cleland with Mark as well. So these people, this study was looking at what did patients want to get? What did they think was going to work for them? And there's a variety of things, but the most important one, I think, that I want to highlight here is if you manipulation. Did you think that manipulation would work for you, or immobilization, or manipulation, a thrust manipulation for neck pain? Did you think that that was going to be beneficial for you? Okay, so that expectation, I think that's going to work for me. And then they looked at whether or not the patients who got that treatment versus the ones who didn't get that treatment. I thought it was going to work for me, and I didn't receive it. Their outcomes were terrible. I thought it was going to work for me, and I received it. Their outcomes were great. Maybe not so much difference between the patients in terms of clinical presentation, but it was a matter of the study structure. And so expectations. If you think something's going to work, then it will. You know, it's that wonderful thing. So creating positive expectations is really important. It works with TENS. This is a really recent study, just published a month or so ago in the Clinical Journal of Pain, that the way the physical therapists were taught to present TENS in either a neutral fashion, a negative fashion, or a very positive fashion, that this is going to really help you. So the way that the therapist presented it to the patients really impacts the way that the patients respond. So, I mean, we know that, right? But it's important to remind ourselves of that, how we So how we present things as, you know, this is going to work, this isn't going to work, well, I don't know, maybe we should try this. You know, last-ditch effort, let's go ahead and talk about pain neuroscience. They're not going to buy into it. So through positive attitudes towards it, not being, you know, cheerleader, rah-rah, but it has a huge impact. We have a lot of responsibility then to be very ourselves about the evidence that should be driving our practice, and not just be based upon old school stuff that we sort of think works. But the therapist's expectations is another confounding factor. So there's some really interesting literature out there that looks at our own orientation, our own fears about movement, our own beliefs about things, the biomechanical nature of pain, and many physical therapists were really educated in that, really a biomechanical approach. And if we have that instilled in our mind, that's the way we're really thinking, that then we're going to be much more likely to be giving advice about restricting activity or being constantly vigilant about the kinds of pain that if it hurts, don't do it, those sorts of things. So our own biases are going to influence what we're going to be doing in the clinic. And so I love this quote: we draw heavily on our own beliefs. These factors might influence the patient outcome through over and under treating. And so that's an important thing to me. Of course, when we're talking about evidence-based practice, we're talking about the three-pronged approach, right? So there's the evidence that comes from randomized clinical trials and other sorts of research. We're talking about our own experience, and our own skill level, and also what the patient wants, because we just talked about that, and their things. So those are the three bases, right, of evidence-based practice. But I guess what Chris Main here is saying is that we're very careful about keeping ourselves on top of the new advances in treatment that we're open to having different ways of thinking, and we can change our own approaches. Am I saying that well enough? Okay. All right. So pain neuroscience education is not indicated for everyone, all right? It's indicated for patients who have central sensitization and some maladaptive kind of cognition, ruminating, catastrophizing, fear of movement. Their best coping strategies may be to avoid movement. So so since it hurts when I walk a quarter mile to the grocery store, I'm not going to go to the store anymore. Those kind of coping strategies. So patients who present in this manner would benefit from intense pain neuroscience education. The person who has, positive coping strategies, they're going to go ahead and do what they need to do anyway. They have positive affect, and they're very resilient. No, give them the exercises and get them out the door. Yeah, so I think this is one of the reasons. So I do think that the patients who you think may go in that direction, it's worthwhile. Now, there's some new tools that are getting out there. The Start Back tool, this one, it's a screening tool that can be used in primary care to identify patients who have some psychological or psychosocial factors that may indicate risk for progressing to persistent or chronic pain. And so those patients you want to really would be very, very alert to the kind of ones we use and start to introduce these concepts early on. Really great question. Okay. Oh, going the wrong way. All right, so does pain neuroscience education work? Well, of course it does. Otherwise, we wouldn't be here, right? So just to kind of talk about it a little bit. So first of all, this systematic review. This is an updated systematic review. One was done 5 years ago, maybe. This one just published in 2016. Looked at 13 randomized clinical trials, and the evidence isn't overwhelming. Early studies were not done so well. Huge variety in the way that the education was delivered from one study to another study. So we're not saying like, oh my gosh, this is a panacea, right? It's just not. But this is the most interesting one to me, evidence for decreased healthcare utilization after PNE. The 3 studies that looked at that, all 3 of them saw substantial decrease in healthcare utilization for the period afterwards. Loved that. Improved function or disability, most of the studies showed improvement. So usually measured using the Roland-Morris Disability Index or the Oswestry Disability Index, or I don't know which other ones were used there, but some of those standardized instruments. Some of the studies had some improvement, some of them didn't, but again, the variety, the variability between the studies is pretty dramatic. One, for example, was classified as PNE, but it was given a book. Here's a book. Read this, come back and let's talk about it. Others were much more intense. We're going to have 30 minutes today and 30 minutes next time, or even an hour of education today and then another follow-up. So big variability there. Some indication of some decreased catastrophizing. But the most interesting thing is that PNE, when done in combination with other therapeutic approaches, so manual therapy, exercise, one was healing. So when you're not doing it as a standalone, there are more beneficial outcomes. Those studies had better outcomes than those that were just PNE alone. Off at 8? Okay. Yeah, no, I just wanted to make sure I knew where I was going. Great. Okay. Okay, so this one is relatively recent. So these people with the triangles, they were taught how to activity pace, how to do pacing that was time-based pacing, not pain-based pacing, not stop when it starts to hurt. Of course, but we agreed to pace your, go and do this, you go weed your rose garden for this period of time, and then you stop, regardless of whether the pain comes on or not. So it's an interesting approach. So, and that's compared to pain education, which is the dotted line. So no surprise, the patients randomized to the pain education, they know more about pain than the other ones. Well, yeah. Okay, but they have a substantial decrease, a significant decrease in catastrophizing compared to the pacing group. You would think pacing might, over time, help with catastrophizing because you're able to do things and you're not paying attention to the pain, but not so much. Slight improvement in worrying, or a better performance in worrying. They aren't worrying as much after PNE, and not so much difference in terms of their use of distraction as a way to cope, so not paying attention to that. But it's interesting that we can have some pretty substantial effects. And this is, I think, the last study I'll talk about. It's looking at preoperative PNE for patients who are going to have lumbar surgery. Okay, so they're already decided it's going to happen. We're doing the surgery, whether that's right or wrong, no judgment here. Randomized to either going into a PNE or to just usual care. All right, and so they have an hour session, I believe, with a therapist, individual session with a therapist, and substantially improved outcomes. There was no difference between these groups in terms of function, long-term function, pain intensity, pain-related disability, none, no difference at all. But satisfaction with their surgery was just great. So your neurosurgeons are going to be calling us up and having us come do these kinds of education so they'll get better patient outcomes and get sued less. Okay? So that's something that's really interesting. It just changes their expectations and makes them more happy with the outcome. So I'm glad that I underwent surgery for my leg pain. Knowing what I know now, I would do this again, given the same choices. I don't know how I feel about this. I just thought I'd put it up there because it is an interesting thing, thinking about doing PNE preoperatively so the patient knows what to expect, knows what pain to expect, and how to interpret the pain postoperatively can benefit them in the long run.
I know you were asking about non-responders, and I actually went to a couple of Adrian Lowe's talks during a related study talked about that I had 50% less healthcare spending on patients that were in the group that received 1 hour. That blew my mind. I was total fangirl at the but just that 1 hour. So some of these people you're talking to thinking that they're non-responders, but maybe they are. Maybe as you look at because there's no difference in functional outcomes, the analog scale, the same between groups. So 50% less, they're thinking, they knew, okay, I didn't need an MRI, my pain is not a sign of the structure is wrong, or they don't go to the doctor for every, and I don't know how you measure that as far as our, but maybe some of these people are responders that we might think are not.
That's right. And, and if we think of ourselves as members of the bigger society, we have a responsibility to, help to control healthcare costs, right? The better we can do, the better off we're going to be at society level. Thank you. Yeah. I already talked about that. All right, teaching tips. All right, this can get complicated. And some of us like to use big words. I love words like catastrophizing. That's one of my favorite words. But big words can be really intimidating to patients. And even really, really smart patients sometimes just don't get it. So I've given anybody who's been in my teaching and learning class before, you've heard this story before, but I had a very, very smart friend. She's smart in a humanities smart kind of way. And she went to a physical therapist for her, I can't remember which problem. She's a frequent flyer with us. But she went for, and I think it was for back pain. She had this therapist who was great and graduated the program I was at the time. And she came to me the next week. She said, that she fully believes that he knows what he's doing, that she believes that he was an excellent therapist, but I didn't understand a single thing he told me. Because, he was talking at a different level. He knew she was smart, so he was talking at, his smart level, and her smart level, well, they don't connect in the middle. And so that was kind of using simple language, starting off being more complex as you get to know whether or not the patient is getting it, So that's fun. Use of metaphors. So the books that I have here that y'all can take a look at are just excellent at providing metaphors for things, because it's just easier to think that way. So we have a lion roaring at us. We have buses moving towards us. We have a pain meeting up in the brain. There's just things that patients can relate with. thinking about glasses being too full and overflowing with the fire underneath them, those sorts of things. There's an excellent book here by Lorimer Mosley, Painful Yarns. It tells all these great stories about pain. It's like short stories that you can read and laugh because he's so funny and these are so good, and you can just nod your head and say, yeah, I get that. So you get these stories, from these guys who've written these up so nicely, and share them with your patients. It's very, very helpful. All of the studies that have used P&E that I have read in detail have given written information for patients to read to reinforce the information given in the educational session, because we know that we don't retain everything that we hear. Okay, so giving some kind of educational materials, whether it is a specific book from a specific approach, or a handout to just kind of reinforce that. These are the key points for you. I like the idea, again, of giving the teach back, and maybe one idea is with the teach back thing, kind of doing a bulleted points. So what are the most salient points for this individual patient? And you can do a very individualized kind of handout for them. I keep going the wrong way. Either that or I really liked that slide. Oh, I'm lost. Okay, so pain neuroscience education challenges. All of the studies that have been done have been efficacy studies, controlled studies, not worried about reimbursement. They are individualized. I think all of them are individualized one-on-one educational sessions with people. Okay, so all not real-world settings. Okay, so is that realistic in your practice environment? To take an hour to teach a patient this stuff? Well, it's just not. It's just not, because you aren't going to get reimbursed for it, right? I mean, if you don't need money, then you can do that. You could do it pro bono, no problem. But because we can bill for education, but we're not yet being reimbursed, right? Unless something dramatically has changed and nobody told me about it, you are going to have a really hard time having a business model that can incorporate 1 hour of one-to-one pain education on an ongoing basis. So the challenge is to integrate it with usual care. Now, there's ways to do it. There's little snippets. You don't need to do an hour at a time. You give little lessons, right? You break it down into what's manageable that you can talk with the patient about while they're resting after exercise, or if you are doing, having them ice their knee, or if they're, you're doing something else that's relatively passive, you can be talking with them, not about what they're going to be doing this weekend. That's fun, but what this stuff, this education that might, change, or if what you're doing this weekend, well, let's think about how is that going to be impacting your pain? How are you thinking about that? And what are your plans to make sure that you're able to cope with all of those things? So trying to get it in little bitty bites. Anybody have tips on how they do that? Michelle, you have anything to offer with that? Mm-hmm. Mm-hmm. Right. So that's making use of that time so that it's just really optimizing. So they're really getting the bang for the buck. Boy, that is good quality PT. The other challenges I've mentioned before, health literacy, speaking at the level that the patient can understand. I don't think that these books, these are the two books. This book I don't think is written at a reading level that is manageable for many people, the Protect a Meter. I asked the guy at CSM last year, what's the reading level, and I think that was a really interesting question. He didn't have an answer to me. And I haven't checked. I should actually check. Going the wrong way again. All right, so there are lots of educational resources. I do have these things up here if you want to come take a look at it. Some of you have already seen these things. There is a wonderful video, Explain Pain in 5 minutes. If you haven't seen that yet, you should do it. So just Google Explain Pain in 5 minutes, or go to YouTube, Explain Pain, 5 minutes Explain Pain, and you'll see a delightful little video. So I was going to make but we don't really have time, so I won't. But I will do the plug now. This is a unabashed plug. Neuroscience education, this is an overview. The deeper you know it yourself, the better you're going to be able to explain it to your patient. And so there is going to be application of pain sciences taught as a 2-day course, 16 hours, 16 contact hours. It's didactic and hands-on, lots of hands-on. So you would come away with some real skill development over the course of those 2 days. It's going to be in November, first weekend in November. It's going to be at the Upstate campus. It's being taught by the former director of the residency program, orthopedic residency program at Chica Medical Center, Mike Costello, and Dr. Dalton will be assisting also. So I highly encourage you to consider doing this continuing education course. If you would like me or us to send you additional information about the course when it becomes available. Right now, let's just save the date. We'll give you more information. If you can just find your name on the sign-in sheet and put an asterisk beside it, I'll know that you want us to send you an email. Okay? All right. So in summary, what we're going to be seeing now, hopefully, we're going to see floods of patients coming to PT. They're not going to be on drugs, on these kind of strong drugs anymore. They're going to be coming to physical therapy for a much more positive approach to pain management, a much more positive approach to pain management. So we need to be prepared to work with them as whole people, not just as a knee, back, the joints. We already do that, but really understanding that we have to address the psychological and the social aspects of a pain problem if we're going to really have much chance of getting those patients better. There's references. There we go. Any questions or comments at this point? All right. Thank you so much for your attention. If you want to come take a look at these things, that's wonderful. So, you know I talked to you about conversation now? Yeah. So one of my things is I think this stuff would work really well in groups. And, these are great images. And I really do think that people, I want to know whether or not we could do this kind of education in groups, and then you have people, maybe $5, $10 for a session. Yeah. 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 Maybe I should do that. And what I'm thinking would be a great project for a student who's artistically inclined is to really help develop those maps. There's no exercise data. I know. Thank you so much for your participation. Yes, it's very helpful. I know, it drives me nuts. We all do. I have no idea. It is interesting. Oh, I wonder if I can just turn myself on.
Yeah, I think nice. Similar, maybe. I think the images would be great. I think so.
I know. That's always that.
Interesting. I would still do it more mature, like for me. I totally agree. It was really important. Probably just to get a better sense about it. I mean, I was that's to find out locally with the series of conversations I'm hearing. And it's interesting, yeah, not this is why you're here. Yeah, you're here. I mean, that what you can't do it. I can't see why they're
Right. Yeah. So one of the things, part of the fun I have with it, one of the things, everybody has to do one.
Oh, yeah. Not an army, not an I know.
Yeah.
So, you know, I think those things are so obvious and nice. Like cultural, and if you look at all of them, like just that are
Yeah, I love that. I wrote to the guy who did this. They came on, and I said, you know, what's up with that? They're all white. He says, you're the first person who's ever said they've been